Perfect. So, Joe, could you start off by sharing a little bit about your MEN2a story as a patient, really, and how that's brought you to where you are now, working in AMEND?
Yeah, it's I don't know if it's a typical story or not, maybe, but it's one of those things where when you're diagnosed with something, if you're interested in learning about it, you get more involved, and then you end up where I am, sort of thing. So, but my story is that I'm actually an MEN2a patient, so that means I've had thyroid cancer, medullary thyroid cancer, and I've had 2 adrenal tumors called phaeochromocytomas. And it was actually one of the phaeochromocytomas that was the first thing to give me problems when I was undiagnosed. And I just had my first child in 1996, and I was starting to experience these very sort of sudden onset symptoms. And I would, my skin color is normally quite good, quite healthy, but I would blanch, my lips would go blue, I'd get really bad palpitations and struggle to breathe because of them. And I then started getting really bad and very sudden headaches, and sort of headaches didn't really sort of express the severity of them at the time, so I used to call them migraine attacks. And I don't know if that was helpful or not to the GP, but these attacks sort of kept on happening. They would sort of dissipate for a while, and then they'd come back. And I had a couple of miscarriages, and then I had my son was born in '99, and these symptoms came back a month before he was born, and he was born a month early because of them. And it was after he was born that they became really severe. But then they sort of, it was very strange because they die off and then they come back. And my GPs at the time, I went through a couple of GPs during this period, 4 years. And they would always say, oh, do you know what, I think it's pregnancy hormones. And, so I was kind of expecting it with my second pregnancy. And I sort of thought, well, I'll be prepared, and perhaps I'll go and have some treatments or other, some sort of, backstreet treatments or whatever. But what happened was, when he was born a month early, we stayed in hospital for a week. And my son was put under phototherapy, and he was okay. He was healthy by the end of it, but nobody sort of looked at how I was, and I was struggling to hold him, to feed him. I had no energy. It was absolutely drained. And so eventually my GP decided that I was postnatally depressed and that I needed to go and see a psychiatrist. And I went to see a psychiatrist who asked me whether I could fly, or whether I thought my children could fly. And I lost it at that point. I was busy puking anyway because I couldn't keep anything down. I was an absolute mess, basically incoherent. And so what they did was they, because my husband had private health insurance cover at the time, for me as well, I went into a private psychiatric hospital in Bromley. And they were lifesavers, absolute lifesavers. And within about, I'd say halfway through talking with the first psychiatrist who did the kind of the initial consultation in there. And I think my mum did most of the talking because I literally just wasn't really there in the room at the time. And he'd already written down on the notes, phaeochromocytoma query. And so they did a couple of urine tests while I was in the psychiatric hospital, and they came back just overwhelmingly positive for excess hormones. And they sent me for a scan, and then I was referred to King's College in London, and they'd found this big phaeochromocytoma, and both the kids had been bouncing on it when I was pregnant. So hence the kind of the ups and downs. You stimulate these tumors, they will tend to do things. So in reality, I was actually very lucky I was still alive after this. And then as years went by, I had the family were tested. So my son, who was only 2.5 at the time, I think, was diagnosed with it. My daughter didn't have it. And my mother was diagnosed with it, and then various other sort of family members. So at that point it was, well, you know, you've got this thing, so we're going to take your thyroid out as well. And I already had thyroid cancer, so that came out, and then eventually my other adrenal came out, so I'm adrenally insufficient as well. And then I had a shoulder replacement in 2007 for what they thought was a thyroid cancer metastasis. So we lost that one as well. And my son had a thyroidectomy at age 3.5, which was to try and prevent him developing the thyroid cancer, which to date, and he's now 24, has been successful, and he's a busy full-time chef working in a 45-degree kitchen on his feet all day. How he does that, I don't know, but he's monitored for phaeos and things like that. So the whole family is monitored regularly, and yeah, we receive great care. So it was at that sort of point of initial diagnosis when we got the genetic diagnosis, and I sort of thought, right, well, I kind of want to know more and maybe try and meet people. I know it's rare, but surely there must be somebody we can talk to outside of the family, etc. And of course, in those days, it's sort of almost pre-internet, not quite, but almost pre-internet, very difficult to find anything. Although I did manage to find a family in America who had a daughter around my son's age, and she just had a thyroidectomy, and it kind of helped me make up my mind what to do with my son in that regard. So that was good, and I thought, well, you know, this is sort of thing should be easy to access. And then we've found, my mother had been getting the BTF, the British Thyroid Foundation newsletter, for some time, and she saw a tiny little advert in there saying, have you got MEN1? You know, do you want to help with setting up a society? And that was how my mum and I, both with MEN2a, met with Liz Dent and Emily Fazel, who had just been diagnosed with MEN1. And interestingly, it was both the daughters, it was myself and Emily who had been diagnosed first, and then subsequently our mothers had been diagnosed. And we got involved and said, well, let's create a bigger noise by joining together MEN1 and MEN2. And then as we went along, we learned so much more from the health professionals who we got involved in this new organization. And kind of AMEND was born from there. And I was very lucky that I was not having to go back to work when the kids were young. And besides which, I've been going through all these sort of surgeries, treatments, etc. I need a bit of a break here. And so I sort of got stuck in volunteer-wise and started writing information and learning and going to conferences and things like that, and building up networks and so on. And I did that for sort of 10 years before I then became the CEO of AMEND officially. In a paid salary role. So, and there's never a dull moment, that's for sure. It's a very varied job. It's quite full on, very varied job, and I'm not quite sure what I anticipated doing when I was going back to work after having the kids. It wasn't this, because I wasn't banking on being diagnosed with a rare disease, but this is what it is, and so that's how I came to do what I do.
Wow, I find your story humbling. I really, really do, and it's very interesting because you hear lots of different stories from patients in AMEND, or definitely I do anyway, and outside of AMEND, anyone with an MEN condition, but yours, I think, what you had, the lengths you had to go to get the diagnosis really are quite incredible. And I know you've said before that actually one of the things that you're working on in AMEND at the moment is trying to raise better awareness of the MEN conditions in primary care among GPs, because quite understandably it's a rare condition, it's not, you know, on your tick box of things when you go to see the doctor. How do you think that's going to impact, you know, a patient community going forward, and the next generation of MEN patients?
It's a difficult one because it's a very noisy landscape, because there are lots and lots of rare diseases, and also the more common diseases as well, all shouting in the same landscape. They all want GPs to diagnose people earlier, or to, in our case, perhaps refer on earlier. So I don't think we'll be successful in raising awareness of the MEN syndromes, but I think we might have more luck working with a lot of our international colleagues and medical societies in raising awareness of the symptoms of some of the tumours. So I think that's important. You know, for instance, for the phaeochromocytoma, that was my first my first diagnosis. All the signs were there, and the one thing that got me through at that point was a urine test performed by a psychiatric hospital. So could that urine test be something? In fact, it's less likely to be that urine test now, as there's an improved one, or even a blood test, but that requires a referral. So I think it really is sort of looking at yes, it could be this more common thing, but don't forget about this or these things that it could be. So it's not always going to be a fear, it's going to be something else. And it could even be psychiatric, you know, it could be serious anxiety about something. So a lot of the symptoms of some of the tumours are quite diverse and much more relatable to a lot more common things. But I think what I would love to try and impress, and I do when I go and speak to medical students every year, and I say, you know, so maybe you won't pick that up, but if you've got someone who's ordinarily maybe you've not seen for a while, even if it's regular appointments that are routine, but if someone keeps coming back to you and whatever you're doing isn't working for them, maybe you need to do further investigation into that, maybe think outside the box a little bit. And I hope they all sort of remember that, and I hope that they all remember my story, so that they can think if they go into general practice. I remember listening to that lady one day, and she said, this could be that. So it is a very difficult thing to do, raise awareness with GPs particularly. So we're going to be looking at really the symptoms of all the different tumours that we deal with, and we'll be looking at not just general practice but primary care as well, so your local hospital. So if the GP refers you to a local hospital, it'll be nice if somebody there maybe thinks that step further and does a test. And it's a project that we're hoping we're going to be able to work on more later this year or next year, to really try and develop a resource that will be useful, because a lot of the time, if you can develop a lovely booklet and send it to a GP, and it won't get read, it might get put in the bill because there's so many other bits of paper coming at them. So there's got to be smarter ways of doing it, and that's probably the electronic systems that are in use in primary and primary care.
Thank you for that. I definitely understand when you say, you know, there's a lot of us shouting in a noisy space already, and quite understandably, you know, we're kind of elbowing and tussling to get our voices heard, and it's about, I suppose, as you say, working in a smaller, to make the biggest impact, I suppose, in a smaller area, rather than trying to kind of, you know, make sure that every single GP there knows about, you know, MEN, just in case, you know, a patient should rock up any one day. And I know, you know, you're on the front line of this, and you're going and you're speaking to a lot of professionals a lot of the time. In fact, you went to the World Conference recently, which I know that you've mentioned about. When you are there and you're speaking to experts or anyone, you know, from any particular field, do you think that there's that these, you know, these professionals are very much open to engaging with what patients want, or do you feel like there's very much a separation between this is the medical scientific side and we're going to do, you know, what we need to do, versus, you know, this is the patient side and this is what we want to know and want to understand? Or is there more of a correlation now?
I think it's coming gradually. I mean, I was delighted to be asked to speak at that conference, the World MEN conference, which also incorporates sort of phaeochromocytomas and paraganglioma syndromes, which are sort of another side of what we do as well. And I was asked to give the patient perspective, you know, and I think everyone found it useful, but I think sometimes there are interests that some scientists have, not necessarily clinicians, but some of the scientists who are doing the research have their niche projects, and I don't think it's always aligned to what the patients want. But then patients aren't scientists generally. Well, of course they are, but not necessarily with the diseases that they're researching. And there are lots of different aspects that need researching. So for one thing, scientists need to understand what causes a disease. And so they might be looking at tiny sort of molecular problems, and that might not be exactly what a patient thinks is important at the time. But if you don't understand how a disease occurs or what causes it, then it's probably, I don't know, twice as difficult to find a new treatment for it. You know, they're looking sort of down at the minutest level, because what they're looking for is when you have a protein and it has a pocket, they're looking for a drug that's going to fit in the right pocket and stop a tumor from growing, or whatever it is. So they really are looking at tiny things, not necessarily on a patient's radar particularly. I mean, I think a lot of patients, they want better treatments, they want more treatments, they want more effective treatments, and there are steps to getting there. So I think, you know, these steps are pretty well, you know, decided. This is how this research works, and this is how you get to new treatments. So, and this is why it's taken such a long time. So, yeah, it's a shame, but yeah, I mean, I think we're all generally on the same page. Science-wise or research-wise, I think we're generally on the same page, and it's about patients understanding that before the treatments comes all this other work. And clinic-wise, you know, we've known for a long time that patients need a lot of emotional support, you know, especially just after diagnosis, but also all the way through the journey with a lot of these syndromes. You know, with MEN syndromes, we're living with these for the rest of our lives. And we need emotional support from time to time. Not everybody, but a lot of people do need emotional support, and it's borne out by all our surveys and so on and so forth. And unfortunately, I don't think there are that many places at the moment where that's embedded in the service. I mean, there's been so many cutbacks in the NHS to psychological services. So, I mean, we're lucky that we can offer a few sessions a week for some of our members, but you know, this isn't an infinite resource, and it's an expensive resource. So that's sort of something that needs to be embedded in the centre of expertise. You've got expert doctors, you've got expert nurses, you've got all the lovely tests and scans that you may need. Also, we just need somebody to help with the mind as well.
Absolutely. And I guess that's something that, you know, makes communities like AMEND so important, is, you know, that space to be able to find people who are going through something similar, to ask those questions, to feel as though you're not alone. And, you know, that is part of the emotional support, isn't it? Is that, you know, that sense of community. What we're lacking, obviously, as you say, is, you know, on a more maybe professional level, getting that, I think you used the word embedded in, into our healthcare at the moment. Whether that will ever happen in our lifetimes, who knows? But at least we're aware of it. And we can go looking for it now, because that's so much more commonly discussed, I think, nowadays in disease communities, in patient groups and things. So that's definitely a need that I've noticed as well when I talk to different people. Are there any other kind of other things that jump out to you as needs that are not yet being met for patients, and maybe that's because it's just not possible to provide them, or there's a lack of awareness, or for any reason?
Well, from all the data that we gather and everything, diagnosis is the biggie. That really is the big one, and that is then followed by emotional health. So emotional well-being comes second to actually trying to get a diagnosis in the first place. And I don't know if the two are linked. We've not explored that any further, but it could well be that a delayed diagnosis, which is on average 4 to 5 years for MEN syndromes, has, I mean, I would imagine it would have a massive impact on emotional well-being, and that's probably why that comes in second. And then it's about managing symptoms and managing treatments. So a lot of our tumours secrete extra hormones and cause a variety of very unpleasant symptoms. And there's, from flushing to vomiting to growth issues. There's an extraordinary, there's a plethora of symptoms that can be experienced by any one person, and trying to have those under control is difficult. So, I mean, you do get then to the treatments, because for some of the conditions there aren't as many treatments as we would like. The medullary thyroid cancer is just one of those where we've helped to try and get a temporary approval on a new drug, selpercatinib, which seems to be tolerated really well by people. But at the moment, they have to try another drug, which is less well tolerated, and which people suffer side effects from as well. So you've got symptoms, you're given a drug to help you, and you're given it causes side effects. And sometimes, a dose adjustment might help, but ultimately, I think the patients want to be on the one that has fewer side effects. But then where do you go after that? Because all these things stop working eventually. And this is where the research into new treatments is essential, because as one doctor some years ago put it to me, she said, we're looking to have a toolbox. And so you take one tool out, you use that until it stops working, then you go back to the toolbox and you take another one out and you use that. And so this is the aim, is to have this toolbox of drugs. And this is where all the molecular work comes in. So I think, for patients particularly, it's getting diagnosed, it's having your emotional well-being looked after, it's managing your symptoms while you're symptomatic, and then it's having a toolbox of treatments. And if you've got all of those in place, you can get on with living your life, and that's what a lot of people just want to do. They want to get on with being as normal as possible, and getting on with their life as normally as possible.
I love that little phrase, toolbox of treatments. And I think I've very much, since my diagnosis, I guess, and particularly the last few years, I've created myself a tool. I hadn't really called it this before, but my own toolbox of, things that obviously not treatments, not medications, because I don't prescribe those to myself, but, things that I can do that I know help me on very much on an emotional, psychological, social, physical level as well. And I think that's really important, is knowing where to go, for that support and that help as well. And it's a bit like you said before, understanding that each thing that's going on in MEN1, whether it's the scientists looking at the the molecular, whatever it is, the clinicians doing this with their treatments, and patients obviously, you know, asking for a certain type of care, you know, everything has its place, and it's so easy, I guess, to look at this very blinkeredly and be like, well, you know, this is what I need, so why am I not getting it? But actually there is so much going on behind the scenes that we don't necessarily see, particularly as patients, because, you know, we're very much kind of you know, entrenched in our own experience of it from a kind of non-medical, non-research point of view. But I think that's, you know, it's a really, really reassuring thing, I think, to know, you know, that everyone is doing what they can, to the extent they can, and bringing in, you know, bringing in something different, I think, each time.
Yeah, I mean, I think research wise, I think one of the issues is that, you know, when you're dealing with rare diseases, you need data, because you don't get any drugs approved without data, and there appears to be an increasing appetite now for doing international collaborations. So this is a good thing, because if you've just got a research project based in the UK and it's dealing with MEN1, it's not going to have that many patients, and it's not going to have sufficient data to drive anything through, you know, NICE, the National Institute of Clinical Excellence. So what the World MEN meeting in particular felt, it had a different feeling to it this year, and it's the first physical meeting since before the pandemic, of course, and that always has a little bit more of an edge to it anyway. But you know, a lot of the people who go to this meeting now have known one another for a long time, and so they are collaborating internationally, and that's what needs to happen, definitely. So I'm hopeful that it's happening more and more now.
Absolutely. I think collaboration is so important, and I think I suppose maybe it's an odd way of looking at it, but, you know, the less rare this disease gets, so, you know, the more people are diagnosed, I guess the more, hopefully the more awareness there is, you know, of it, and the more resources are going to be put into it, the more attention, the more time. And as you say, you know, that word collaboration, working, you know, together, and each person coming in, you know, with their own area of expertise, I think is a really important way of moving forwards, and making progress in something that, you know, can feel really quite disempowering, I suppose, but to know that actually things are ultimately being done. It's really reassuring to know.
Yeah, exactly. I mean, we do our own little thing, 2012 to last year. We've been funding very small research grants just to get some of this molecular stuff off the ground, if you like. I hope that the scientists involved don't hear me say that, but anyway, you know, so doing the basic sort of molecular stuff there. So we've been giving small grants out every year while surplus funds have allowed us to, and you know, that's up to £170,000 by last year. I think we'd given away. A lot of that's fundraising from people, which is absolutely extraordinary. And we can't do it this year or next year because we have other strategic things that we need to take care of in the next couple of years, and the surplus funds times are difficult at the moment for everybody and for charities. So but I do know that it's going on, it's still going on, and progress is still being made, so that's good. And I mean, in the meantime, for patients, for sort of emotional support and so on, yes, we have the counselling service. That's not for everybody, but we have peer support volunteers as well. So there's meetings that people, if like me when I was first diagnosed, I was like, well, is there anyone else and can I speak to them, you know? And well now you can, yeah, that's easy. And social media, Facebook, and now Instagram, Twitter, Threads, and Possibly TikTok. I'm not promising anything, but possibly TikTok by the end of this year. I'm way too old for that, but I'm going to give it a go. So, there are things we need to do. We need to reach some of the younger folk, and just let them know what we've got for them. So there are so many ways to take advantage of peer support through a patient charity. I think a lot of people, and particularly men, think patient support groups are about, hugs and, are all a little bit weird, but actually I think everyone finds it useful. They know what we do. If you look at our website, you know what we do. It's information and it's support, and that support comes in various guises, and you don't have to do it if you don't want to, but it's there when you need it. So yeah, a couple of the goals for the next year or two is actually to try and reach more men and reach more young people. So hence the TikTok.
Wow, definitely looking forward to seeing some TikTok reels
Oh,
coming up, maybe
dear.
in the not too distant future.
We will not be doing any dancing in the office. Just let me put that down there straight away.
No, I don't either, not on my TikToks, and yeah, I leave that to the kids who know what they're doing. Brilliant. Well, unfortunately, I could honestly chat to you all day, Jo, but we've already managed to get to half an hour. That's crazy. Thank you so much for your time. It's been amazing to chat to you, and I think for people to hear these two very interesting perspectives you've got, which is as a patient and also, working in the capacity that you do, and those are by no means separate, how you can bring those together and be making the progress that you are with AMEND, and what you're doing is incredible. And I personally, I've had so much support over the years, and I continue to now, and I only hope that things keep moving forwards. Yeah, so thank you very, very much.
You're very welcome, and thank you very much for the support you give to AMEND, because I know your yoga sessions at the information days are very well received.
Well, I'm very glad. If there's anything I can bring, I know that, yeah, it's sometimes just a little bit of stretching and breathing can work wonders after a long day. So
totally, yeah.
Very, very glad to. It's a pleasure. Yeah. Anyway, thank you, Jo. I'll stop the recording.
Thank you.